A 67-year-old man, someone who had been active his entire adult life, who never smoked, who watched what he ate, and who genuinely believed his daily exercise routine was one of the best things he did for his health, walked into his cardiologist's office last spring for what he expected to be a routine follow-up. His doctor reviewed his results, looked at him carefully, and said something that stopped him cold. What they found was not the result of neglect. It was not the result of inactivity. It was, in part, the result of the very exercise he had been faithfully doing for years, the one he was most proud of. He had no idea. And because of the timing of that appointment, because of a test ordered almost by chance, the outcome was different from what it could have been. What his doctor explained to him that day is information that most people over 60 are never given. Not because doctors are hiding it, but because the conversation rarely happens until something goes wrong. I am not sharing this to frighten you. I am sharing it because what he learned in that office and what I'm about to walk you through may be more relevant to your daily routine than you have ever been told. What his cardiologist said that afternoon, and what the research behind it consistently confirms, is exactly what you're going to learn right now. What makes that story so important is not how unusual it is how common it is. Because that man is not an outlier, he is a pattern. And the pattern repeats itself in doctors' offices across this country every single week. And people who are trying to do the right thing, who are making genuine effort, who have built habits around the belief that more movement always means more health. The exercise at the center of this conversation is high-impact, repetitive cardio, specifically the kind most often associated with a generation that grew up being told it was the gold standard of fitness. Running. High-intensity aerobics, repetitive jump-based movement, the kind of sustained, pounding, high heart rate exercise that was once considered the benchmark of a healthy, disciplined life. For decades, this was the advice. Push hard, sweat more, feel the burn. And for younger bodies, bodies with more cartilage cushion, more hormonal protection, more vascular elasticity, that advice had real merit. But the body at 60 is not the body at 30. It is not the body at 40. And the science that has emerged over the past 15 years has begun to paint a very different picture of what high-impact repetitive exercise does to the aging body when it is sustained over time without modification. The joints feel it first. The knees, the hips, the lumbar spine. These are the structures absorbing the repeated ground force impact of every step in a run, every jump in an aerobic sequence, every landing in a high-intensity interval. At 67, the cartilage that once acted as a natural shock absorber has thinned. The synovial fluid that keeps joints lubricated has decreased. The tendons and ligaments surrounding the joint have lost some of their elasticity. Every impact now travels through structures that are less equipped to handle it than they once were. And the damage is cumulative, which means it builds slowly, quietly, without dramatic warning signs, until one day the joint is inflamed, the range of motion is reduced, and the pain that was once manageable becomes constant. If you have been doing this kind of exercise for years, if running, high-impact aerobics, or vigorous repetitive movement has been part of your weekly routine, then what happened to that man at his follow-up appointment may feel more familiar than you expect. What his doctor found was not just in his joints, and that is where this story becomes something more urgent than a conversation about cartilage. What was happening beneath the surface, in his cardiovascular system, is where the medical reality of this takes on a different kind of weight. The cardiovascular piece of this is the part most people are never told, and it is the part that changes how seriously this conversation needs to be taken. Here is the foundational medical reality. The aging heart is not simply a smaller, slower version of a younger heart. It is a structurally and functionally different organ. After 60, the left ventricular wall can begin to stiffen. The electrical system governing heart rhythm becomes more sensitive to stress. The coronary arteries in many people carry decades of low-level plaque that has never caused a symptom but exists nonetheless. And when sustained high-intensity aerobic exercise is applied to a cardiovascular system in this condition, repeatedly, week after week, year after year, it can trigger a cascade of responses that the research now recognizes as genuinely dangerous for a subset of older adults. The condition cardiologists are increasingly watching for in this population is called exercise-induced cardiac remodeling, specifically a pattern of right ventricular stress and atrial fibrillation risk that emerges in people who have maintained very high volumes of vigorous cardio over decades. Studies published in journals, including the Journal of the American College of Cardiology, have found that long-term endurance athletes over 60 face a measurably elevated risk of atrial fibrillation, an irregular heart rhythm that dramatically increases stroke risk compared to moderately active individuals of the same age. The man in that follow-up appointment had been running 5 days a week for 11 years. He felt strong. He had no chest pain. He had no shortness of breath that he could not explain away. What the monitoring revealed was a pattern of intermittent arrhythmia, brief, silent, completely unnoticed episodes of electrical irregularity in his heart that had been occurring without a single symptom he could identify. This is the danger that sits beneath the surface of what feels like healthy commitment. And the joint damage compounds it, because when the knees and hips begin to degrade, people often push through the discomfort, increasing intensity to maintain the same cardiovascular output, which further stresses the cardiac system precisely when it is least equipped to handle additional load. If you've been pushing through joint discomfort to maintain your cardio routine, if you have told yourself that the ache in your knee or the stiffness in your hip is just part of staying active, that pattern is exactly what the research is now asking us to examine more honestly. And the reason timing matters so much in this conversation, the reason that appointment changed everything for him, is something we need to address directly. What changed for that man was not the discovery of a catastrophic event. It was the discovery of a trajectory. And that distinction is everything, because a trajectory caught early can be redirected. A trajectory ignored becomes a destination. The concept at the heart of early intervention in both joint health and cardiovascular health for seniors is something researchers call the modification window, the period of time during which the body still has enough structural resilience and adaptability to respond meaningfully to a change in approach. That window is real, it is measurable, and it is not open indefinitely. In the context of joint degradation, the modification window refers to the stage before cartilage loss becomes irreversible, before bone begins contacting bone, before the inflammatory cycle becomes self-sustaining, before surgical intervention becomes the only remaining option. Orthopedic research from institutions including Johns Hopkins and the Mayo Clinic consistently identifies this window as the most critical period for conservative intervention. Targeted movement changes, load reduction, strength training to support joint architecture, and anti-inflammatory nutritional support. The people who catch joint degradation in this window, before the pain becomes constant, before the damage is visible on imaging, have outcomes that are dramatically different from those who wait until symptoms are undeniable. In cardiovascular terms, the modification window refers to the period before arrhythmia becomes chronic, before arterial stiffening advances beyond a reversible threshold, before the heart's electrical system becomes persistently dysregulated. The research is consistent on this point. The heart at 65 or 67, if the load is appropriately adjusted and supportive habits are introduced, retains a meaningful degree of adaptability. The cardiologist who reviewed that man's results told him something that stayed with him. He said, "The problem is not that you exercised. The problem is that you never changed how you exercised as your body changed around you. The exercise stayed the same. The body did not. And the gap between what the exercise demanded and what the body could safely sustain grew wider every year, silently, without announcement, until a test finally gave it a name." The advantage you hold right now, at this exact moment in this video, is that you are learning this before a test has to give it a name for you. Early awareness does not just change outcomes. In cases like this one, it changes the entire story. And the signs that this gap has already begun to open, the signals most people dismiss as normal aging, are what we need to look at very carefully next. This is the part I want you to stay with, because some of what I am about to describe may feel very familiar. And if it does, I want you to take that recognition seriously rather than explain it away. The warning signs that high-impact repetitive exercise is damaging the aging body fall into two categories: the ones people feel in their joints and the ones they feel, or more accurately, do not feel, in their cardiovascular system. In the joints, the early signals are almost always dismissed as ordinary aging. A stiffness in the knees after sitting for more than 20 minutes. A dull ache in the hips that takes longer each morning to work through. A sensation of grinding or clicking in the knee during movement that was not there 2 years ago. Swelling around the knee joint that comes and goes without a specific injury to explain it. Pain that begins during exercise, eases slightly once warmed up, and then returns with greater intensity after cooling down. These are not random inconveniences. They are the joint's attempt to communicate that the load being placed on it is exceeding its capacity to recover. In the cardiovascular system, the signals are quieter, and that quiet is precisely what makes them dangerous. A fluttering sensation in the chest that lasts seconds and then disappears. A brief awareness of the heart beating irregularly, not painfully, just differently, during or just after vigorous exercise. Fatigue after a workout that seems disproportionate to the effort. A heaviness that persists for hours, rather than the recovery that used to come within 30 minutes. An elevated resting heart rate that has crept upward over months without explanation. Occasional lightheadedness after a run or high-intensity session that you attributed to dehydration or heat. Each of these signals individually can be explained away, and that is exactly what most people do with them. They explain them away, one by one, until the cumulative picture is too large to dismiss. The man who sat in that cardiologist's office had experienced the flutter. He had noticed the post-workout fatigue. He had told himself both were signs of working hard. If you recognized anything in that list, the stiffness, the flutter, the fatigue that outlasts the effort, I want you to type the words "not anymore" in the comments right now. Because those two words are the beginning of a different relationship with your own body. And what turns this around, what the research shows actually protects the aging cardiovascular system and preserves joint health without sacrificing the fitness that matters, is exactly where we go next. What changed for that man in the months after his appointment was not a retreat from physical activity. That is, the first thing his cardiologist made clear. Stopping movement entirely is not the answer. Inactivity at 65 or 67 carries its own serious risks for bone density, for metabolic function, for cognitive health, for cardiovascular baseline. The answer is not less movement. The answer is smarter movement. And the first layer of what smarter movement looks like for adults over 60 begins with understanding the difference between high-impact and low-impact cardiovascular training, and why that distinction matters more with every passing decade. Low-impact cardiovascular exercise, walking at a brisk pace, swimming, cycling on a stationary or low-resistance bike, using an elliptical trainer, delivers cardiovascular conditioning without the repeated ground force impact that degrades joint cartilage and stresses the aging heart's electrical system. Research published through the American Heart Association consistently supports moderate intensity, lower impact cardiovascular training as the optimal zone for adults over 60, providing measurable improvements in arterial flexibility, resting heart rate, VO2 max, and cardiac efficiency without triggering the arrhythmia-promoting stress responses associated with high-intensity, sustained effort. The target heart rate zone for this population, generally defined as 50 to 70% of maximum heart rate, is the range where the evidence is strongest, where adaptation occurs without overstress, and where the cardiovascular system is being trained rather than strained. The second critical component of the first layer is resistance training. Not the heavy, ego-driven lifting that belongs to a younger body under different hormonal conditions, but deliberate, progressive, joint-supported strength work. The reason this matters for joint health is structural. Strong quadriceps reduce the compressive load on the knee joint by as much as 30%, according to orthopedic research from the National Institutes of Health. Strong hip abductors and glutes protect the hip joint. A strong posterior chain, the muscles of the lower back, glutes, and hamstrings, supports the lumbar spine through every movement of the day. The man who left that appointment replaced his 5-day-a-week running habit with 4 days of brisk walking, 2 days of resistance training, and 1 day of water-based exercise. He did not lose fitness. His 6-month follow-up told a very different story from what his initial results had shown. But there was a second layer to what changed, and it may be the piece most people overlook entirely. The second layer of what protects the aging body from the damage that high-impact exercise accumulates over time is not about what you do during exercise, It is about what you do outside of it. And it begins with something called recovery architecture, the deliberate, structured approach to the 23 hours each day that surround your movement. One of the most consistent findings in exercise physiology research on older adults is that recovery capacity diminishes significantly with age. A 40-year-old who runs 4 days a week and sleeps 6 hours a night may maintain that pattern for years without visible consequence. A 67-year-old doing the same thing is operating with a fundamentally different recovery timeline, one where tissue repair is slower, inflammatory response is longer, and the cardiovascular system requires more time between high-demand sessions to return to baseline. The man's cardiologist described it plainly. At your age, the exercise is not the only variable. Sleep is a cardiac intervention. And the research supports this absolutely. Studies published through the National Institute on Aging confirm that adults over 60 who consistently sleep fewer than 7 hours per night demonstrate significantly elevated markers of systemic inflammation, the same inflammatory environment that accelerates joint cartilage degradation and contributes to arterial stiffening. Prioritizing sleep, not as a lifestyle preference, but as a physiological necessity, is one of the most powerful protective measures available to the aging cardiovascular and musculoskeletal system. The second component of recovery architecture is nutritional support for both joint tissue and cardiac function. Omega-3 fatty acids, found in fatty fish, walnuts, and flaxseed, have demonstrated anti-inflammatory properties in multiple peer-reviewed trials relevant to both joint health and cardiovascular risk reduction. Adequate protein intake, which the majority of adults over 60 are chronically under-consuming, is essential for muscle tissue repair after any form of exercise. Harvard Health research identifies 1.2 grams of protein per kilogram of body weight as a reasonable target for active older adults, a number most people in this demographic never reach. And hydration, basic, consistent, deliberate hydration, maintains the synovial fluid that cushions every joint in the body. These are not complicated interventions. They are the unglamorous, undramatic, deeply evidence-supported habits that separate the people who move well at 75 from the people who cannot. The man at the center of this story implemented all of them. And what his one-year follow-up showed is the kind of outcome that reminds you why catching something early is so different from catching it late. You are not the person in that story who almost missed it. You are the person who found out in time. That is the position you are in right now. Not in a hospital, not in a follow-up appointment reading results you were not prepared for. Here, with information in your hands that most people your age will never seek out because they do not know they need it, because no one told them the conversation was necessary. Everything you have learned in this video is now part of how you move forward. The difference between high-impact and low-impact cardio, the modification window that still exists for you, the joint signals that deserve attention rather than dismissal, the cardiovascular signs that should prompt a conversation with your doctor rather than a personal explanation. The recovery habits that are not optional additions, but foundational supports. You carry all of that now, and you carry it before symptoms forced you to find it. I want to be direct with you about something. I share stories like this one because the people behind them are real. That man who sat in his cardiologist's office, the one who had been running for 11 years and had no idea, he changed his habits. His 12-month follow-up showed no recurring arrhythmia. His knee inflammation, which he had quietly accepted as permanent, improved measurably. He told his doctor he wished someone had explained this to him 10 years earlier. You just received what he waited 10 years to hear. So before you close this video, I am asking you to think of one person, a friend, a sibling, a spouse, a neighbor, who is still where he was before that appointment. Still running, still pushing, still believing that more intensity always means more health. Share this with them. You could be the reason they walk into their next appointment informed rather than surprised. You could be the reason their story ends the way his did, and not the way it almost did. Stay with us. We will keep bringing you what you deserve to know before you need to learn it the hard way.